Hi, I'm going to talk a little bit about decision-making process PowerPoint. So objectives identify factors influencing decision-making, describe the characteristics of an effective decision maker, define the decision-making approaches and common errors, discuss the decision-making process, identify the rights and guidelines for delegation, identify the clinical situations in which delegation by a nurse is appropriate, and the role of providers. So decision-making is a purposeful and goal-directed effort applied in a systematic way to make a choice among alternatives. Factors influencing our decisions are perceptions, emotions, values, and setting. Of course, nothing happens in a vacuum. We are always affected by our previous experiences, the way we're seeing a situation, and our emotions can color the way we see the same situation at different times, one time viewing it negatively, one time viewing it positively, strongly or weakly. Emotions have a big effect, and everything else that's happening at the time. If we have one sick patient, but we have many sick patients, that's worrying us. But at the same time, we have a lot of other sick patients. We may not be able to give the attention or the thought or the detail of thinking in order to make a good decision. And our values, and of course the setting, and that goes back to talking about the situation. Effective decision makers are proactive, meaning we tend to act rather than react. We plan, have a plan, what if, to have a direct, direct path that we want to follow if we know that something happens. Decision makers tend to be assertive, meaning that their decision is acted on by their own, and not necessarily dependent upon those of their co-workers. So, decision makers are knowledgeable, and they tend to be focused. They're focused on that decision and not a million other things. So, ways we can make decisions are task forces that study something, quality circles that study, but they tend to already have an expertise. Brainstorm, where we just simply generate a large amount of ideas without having any value judgments immediately on the ideas that are generated. A nominal group allows for everyone to make a suggestion, and then they slowly hone that down. Consensus groups can be made revising proposals until the entire group accepts, and that's what happens a lot of times with a nominal group. And majority rules made by a democratic situation in which everyone has a voice and the majority rules in that decision. One thing I always talk about making group decisions, we can develop what is known as groupthink, where the first idea sometimes becomes the best idea, or an idea that has immediate appeal to people can kind of seduce everyone into having the same thought. It doesn't always work out for the best. Situation that I remember is, it's been a couple decades, but had a movement at Massillon Community Hospital that I worked at the time, where they wanted to encourage employees to come up with ideas, to brainstorm, ways of saving money, ways of improving care. And so at that time, it was normally to call something good bad, if that makes sense. Well, that's a bad looking car. That's bad. It was just some part of the colloquial talk at the time. So they came up with the idea that they were going to have this situation where they were looking for bad, meaning really good ideas. So they printed out, I think, 250, maybe even more, coffee cups that were black, and they had a villain on it where he's hiding behind his cape and it's saying, "I had a bad idea." So they then attempted to sell this idea to the rank and file and the employees of the hospital, and it didn't work because people thought they were going to be made fun of if they came up with a bad idea. So I can remember, them handing out wholesale after a few months these coffee cups instead of giving them to people when they had a bad idea. And I can even remember seeing, the guy that carried the trash out with a trash cart full of them. So groupthink can be a bad idea, and bad in the true sense. There's errors in decision making, and that's kind of what I was alluding to. There's bias, that we tend to believe the first idea is the best idea. Failure to look at the whole situation and to know that so many things affect what's going on. What's the backstory in a particular situation? And sometimes people are just impatient and they want to make a decision even if it's the wrong decision. Tools, clinical pathways where we have a standard plan for a patient to follow. Post-op cardiac patients, that night or that day, if the surgery is earlier in the day, they try to get them extubated. If it was real early in the day, they may try to get them out of bed that night. For sure, the next morning and the next day, they're going to be gotten out of bed. And it's going to look at getting out the chest tubes in possibly day 2, but usually day 3, and for them to follow that pathway through the rest of the treatment. An algorithm, if A happens, then we should do B. Or if we have a situation or we respond, is this situation exist? We follow one pathway, and if that situation doesn't exist, we follow a second pathway. Excuse me. It can be 5 o'clock in the evening on any day of the week. You never would know when or it could be 8 o'clock in the morning. The landscapers are going to decide they're going to cut the grass and blow off the driveways and sidewalks. Just makes for a fun day. We can look, if you're familiar with ACLS or even the BCLS, we have a certain, there's an algorithm that we follow. That, if one situation exists, then you do one thing. If the opposite, then you do another thing. So, and of course, we can make decisions by a cost-benefit analysis. That could be extended to in patient care where we're looking at a risk versus benefits. We're going to take such and such a patient to surgery. He needs surgery, but do the risks, because he has comorbid conditions, he's hypertensive, he's very sick, we're not going to necessarily, he would probably survive the surgery. So that the risks far outweigh the benefits, unless of course the patient wants that to happen, that surgery, despite the risks. The nursing process, we make decisions, we assess, we analyze, we diagnose, and we identify our outcomes, we establish, we plan, we implement, and we evaluate that. We've talked about ADPI a number of times. Our standards guide our decision making, and our standards, what would a normal, prudent, meaning wise, nurse do in this situation? What's the typical thing to do? So, of course, we're always tempering that with patient-centered care, with what the patients and the families want. It integrates all their ethical provisions in all areas of practice. I did add a video, a podcast from one of my favorite authors, Malcolm Gladwell. You'll hear me talk about him all the time because he does fascinating work about the way the influences of our actions and how sometimes how we're a victim of fate and destiny, and how sometimes we have so little decision making in our own actions. Love the way he writes. So he provides us a framework for making decisions that have an ethical concept, and he describes the performance enhancing drug crisis of baseball, within the last 20 years. So nurses also integrate research. We're always in trying to improve what we're doing. That's why research and constantly rethinking what we're doing in light of COVID is so important. You read the article that I put out the last couple of weeks about the supercomputer analysis of the coronavirus and how that's changing the way that we affect. That's why it seemed inconsistent through the first few months of the pandemic, because the word novel is sometimes taken lightly, but we have no experience, so we don't know. And the other piece to this whole concept of the pandemic, we don't know what the long-term effect of the coronavirus, having COVID is going to do in our bodies, even if we have minimal symptoms. Case in point, there's people have chicken pox. They can have issues their entire life because of their chicken pox. Anytime they become immunosuppressed or immunocompromised or stressed, they can develop shingles. So we don't know what the long-term effect's going to be. So we're constantly improving and changing our care based on new information. Nurse always looks at factors concerning to safety, first and foremost always, effectiveness, the cost, and the impact in practice and delivery of nursing care. So be able to deliver that care in the best way possible. And the nurse provides leadership and profession in the practice setting. Now, physicians, they're leaders, but they're not constantly in contact with the patient and in the practice setting. Decision making that we make in our clinical practice, evaluating the workload, do we need to rethink and redistribute? We prioritize our care. One question that I always, when I precepted students in the critical care unit, is that I would ask them, which patient they would go see first in the morning. The scenario would be like, okay, you have two patients in a critical care unit. One of them is sick, very sick, ventilated, but stable. And the other one is probably going to go home that day. Which person, but they still have some things that need to be accomplished. Which person should you see first in the day? Provided that really sick one is stable, I would go see the one going home that day first, because I could get that done quickly. And rather than get tied up in the really, really sick patient, I would get the quick one done first, and so I wouldn't be behind in two patients. We monitor and constantly re-monitor patient conditions. We're contacting providers, and we know when to contact them. We're interpreting data and results of tests. And there's now hospitals have a policy and procedure in place where, when do you call a critical finding in a lab and document it. And we're always incorporating our skills and our knowledge and utilizing our resources and delegating tasks as our resources change. Some weeks we don't get our walks blown off once. Today we've got it done twice. So, and we try to establish our priorities in our action care, develop an action plan, know what our desired outcomes and what interventions we're going to do, and have a plan of what things we're going to have to accomplish during the day. But we're going to individualize that care to each patient and their particular condition, and assess how what level of acuity they have, which ones we're going to see first, and monitor for change and delegate as we need to, or rethink and recant what we're planning on doing. Okay, thank you.